Ms. B is a 50-year-old woman with well-controlled HIV whose hot flashes and vaginal dryness are now attributed to perimenopause. With the diagnosis established, the next step is management. Management begins with assessing symptom burden, patient goals, and patient education. Ms. B can record how many hot flashes she is experiencing in a 24-hour period over the course of 7 days to 1 month and share these findings. Her hot flashes are disrupting sleep and causing daytime fatigue, so the clinician clearly explains menopause and related stages, helping her understand why these symptoms occur, what changes to expect, and which treatment options may help. Lifestyle measures should be discussed with all patients. In Ms. B's case, recommended strategies include layered clothing, avoiding triggers such as caffeine and alcohol, maintaining regular exercise, a healthy diet, and using a fan or keeping her room cool at night. If symptoms remain bothersome and there are no clear contraindications, menopausal hormone therapy, MHT, can be considered. In this case, she is under the age of 60 years, within 10 years of menopause onset, has no history of venous thromboembolism or breast cancer, and her overall clinical picture supports treatment consideration. It is important to review the FDA-approved guidelines for the use of MHT and make a collaborative decision with the patient based on her health history and treatment goals. When MHT is used, the preferred treatment option in this case is a transdermal estradiol patch. The transdermal route is often favored because it may lower risk for venous thromboembolism and avoids first-pass hepatic metabolism. Because Ms. B has an intact uterus, endometrial protection is also needed. In this setting, oral micronized progesterone should be added. Before treatment is prescribed, potential drug interactions between antiretroviral therapy and MHT must be reviewed. Some antiretroviral regimens may reduce estrogen exposure, so the treatment plan should always be checked against the patient's ART regimen. Ms. B's current regimen is bictegravir, emtricitabine, and tenofovir alafenamide. If menopausal hormone therapy is contraindicated, declined, or not preferred, non-hormonal medications can be considered. These may include selective serotonin reuptake inhibitors, SSRIs, such as paroxetine. Other choices include gabapentin or neurokinin receptor antagonists. If Ms. B decides not to use systemic MHT or is not receiving effective management for her vaginal atrophy on systemic MHT, she may consider treatment with vaginal estrogen. This treatment has minimal systemic absorption of estrogen. In women with HIV, menopause management is not only about symptom relief. It is also an opportunity to assess and discuss bone, cardiovascular, and psychological health. Women with HIV may be at increased risk for osteoporosis and cardiovascular disease, and pre-existing depression, anxiety, or sleep disruption may worsen during menopause. Bone health should be addressed directly. Depending on the patient, the management plan may include a baseline DEXA scan, calcium and vitamin D assessment, and counseling on weight-bearing exercise. Cardiovascular health should also be reviewed as part of menopause care. Ms. B has hyperlipidemia, and her family history includes hypertension and hyperlipidemia, so this visit is an opportunity to reassess cardiovascular risk while planning treatment, using the 2026 dyslipidemia management guidelines. Psychological health assessment is also important. Menopause can intensify depressed mood, anxiety, and sleep disruption, so clinicians should validate symptoms, assess mental health concerns, and offer ongoing treatment and support. So the key management point is this: menopausal symptoms in women living with HIV can often be treated effectively, but clinicians need to routinely incorporate menopause assessment into their review of symptoms. Remember, treatment must be individualized. Clinicians should review ART interactions, choose therapy carefully and collaboratively with their patients, and use the menopause clinical visit as an opportunity to address broader midlife health.